So we finally made it to 20,000 subscribers, and like I said, I'm going to be dropping these videos quite slowly so that you can actually get the gist of the ECG and we can actually interpret the ECGs together. Remember that you should watch the first video, part 1, and make sure that you understand the concepts from part 1, because if you do not understand the concepts from part 1, part 2 will not make sense, and that's how you end up getting lost and think that it's too complex and you can't really interpret the ECG. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. In this particular video, we're going to be looking at part 2 of ECG interpretation. This is the ECG bootcamp. In this video, we're going to be looking at the rate and rhythm determination. So we'll pretty much introduce the steps that we're going to be undertaking when interpreting the ECG. Notice that I'm going to be displaying certain pathologies that I will introduce slowly, and at the end of this bootcamp we will cover a certain number of conditions that are important in terms of important ECGs that you need to know, different abnormal rhythms, such that you'll be able to pick up these patterns when you report them on the ECG. Big disclaimer, like I said, don't watch this video if you have not watched part 1. If you haven't watched part 1, pause this video, head over to the playlist, watch our part 1 of this particular ECG introduction, because once you understand that, then this makes this lecture a bit easier for you to grasp and a bit easier for you to understand. If you're still waiting here, I don't know what you're still doing here if you haven't yet watched part 1. So pause the video. I'll keep emphasizing this. Pause the video, go watch part 1 of these lectures. So grab a piece of paper, let's jump right into this particular lecture. So remember that interpretation of your ECG should follow a systematic pattern so that you can ensure that you don't miss out on any pathology. How I arranged the schematic and how we are going to be interpreting the ECG, I made sure that I put assessment of hypertrophy, assessment of ischemia and infarction as the last things that you do in the ECG, because sometimes you're going to be blinded just by looking at ST segment elevation and you may miss other important aspects on the ECG. In the emergency setup, it's very quick for you to be able to get a very good general impression of an ECG because you don't have that time to sit and actually write down a report, and you need to intervene very quickly. So you should have a sharp mind to be able to pick up these diagnoses very quickly so that you can institute management. If the patient is a bit more stable, you can actually follow through the steps and actually write an adequate report whenever you're reporting your ECG. Now, what are these steps that we're going to be looking at? There are 7 important steps, not 6, 7 important steps. But think of them as 6 because step 1, even though you may miss it, but very important, especially for those that are taking exams, but in real life, it also helps you so that you don't look at an ECG for another patient and misdiagnose a patient. Very important in real life, very important on the exams. But in terms of interpretation of the ECG itself, there are 6 steps. But my guide here is giving you 7 steps. So step 1 is, of course, checking the patient and ECG details. Step 2 is determination of ECG calibration. Very easy to do. Step 3 is getting a general impression of the ECG. Step 4 is rhythm interpretation, which I break down into regularity, the rate, the P waves, assessing the PR interval, the QRS complex, as well as giving your final interpretation of the rhythm, whether it's a normal rhythm or it's an abnormal rhythm, whether it's a sinus rhythm, a sinus tachycardia, a sinus bradycardia, so on and so forth. Step 5 is assessing the QRS complex in terms of the presence of any RS wave progression, the cardiac axis, any presence of bundle branch blocks, any hypertrophy, and any ischemia or infarction that may be present on your ECG. If you look at these steps of interpreting the ECG, it will make it very easy for you to actually learn. In this particular video, we're going to look at step 1 up until we reach step 4. And in the subsequent videos, we'll look at the other different types of steps. But first, I want you to digest this particular video and the previous video that we have already done. If you understand these videos, only then can you move to the next video, which will focus on the QRS complex. So step 1 is, of course, confirming the name, the date, the age, and the patient file number or the ID, so that you're looking at the right ECG for the right patient. Confirm where it was taken, when it was taken, and the place and the date when it was taken. All these details are usually found on the ECG. So step 2 is of course determining the calibration of the ECG. So remember that here you get a bit of some information that will help you determine certain pathologies of the ECG if it's well calibrated. For example, the height of the P waves, the QRS complexes, the T waves will give you some good indication. For example, if your QRS complexes, or rather your waves, are generally small, you get small complexes on the ECG, this may be perhaps this person is very obese and the conduction is quite poor, or there's an effusion, there's a pericardial effusion that is surrounding the heart. If, for example, you get tall R waves, this may point towards left ventricular hypertrophy. Of course, I'll discuss this a bit later. How do we know that our ECG has standard calibration? We look at these small squares here at the beginning of our wave. So these small rectangle-like shapes, I like to call them these small towers here at the beginning. This tower should be 1 box wide and 2 boxes tall. That's how you know that on the x-axis, the ECG paper is going to be moving at 25 millimeters per second. So it means each small box is going to represent 0.04 seconds. Each big box is going to represent 0.2 seconds. On the y-axis, it means that for every 10 millimeters, every 10 small boxes, it's going to be equals to 1 millivolt. So here's an ECG that's improperly calibrated. In the first two, as you can see, it's of course 1 box wide, but it is like 1 box tall in proper calibration. Again, here it's still 1 box wide, but 1, 2, 3 boxes tall. This one is the correct calibration, where it's 2 boxes tall and 1 box wide. So like I said, if you get this improper calibration, the waves may either appear smaller than they are, or they may appear taller than they are, and this can sometimes affect your interpretation of the ECG. For example, here, this is 1 box short. As you can see, the waves appear small. Here, where it's about 1, 2, 3, 4 boxes tall, the waves are appearing very large, and you may think that perhaps this patient has peaked T waves, but it's all because of the calibration of your ECG. In terms of the width of the box, if the box is 1 box wide, it means each small box is representing 0.04 seconds and each big box is representing 0.2 seconds. And if now this calibration, for example, as shown in this picture, is twice the size of this box, it means that your ECG is now moving at a faster rate. So it means each small box now will be representing 0.02 seconds, and this will spread out your ECG waves, and your ECG waves will look a bit different, or rather put them close together because it's moving faster. So it may look a bit different compared to what is normal. So that's our step 2. Remember where we're coming from. Step 1, we're looking at the patient details, ECG details. Step 2, we're looking at the calibration of the ECG. Step 3, we're going to be looking at the general impression. Take note here, you're not giving any diagnosis, you're just having a quick glance at the ECG so that you can understand what is going on. Ask yourself 3 important questions. What am I seeing? Is it a fast rhythm? Is it a slow rhythm? Are they ugly morphologies? It doesn't look normal. It looks like a weird pattern. So this here is very important because it's going to help you have a quick understanding or a quick impression on the ECG such that you can now help you determine the rhythm. It can help you determine which calculations you're going to do. For example, if you get an ugly morphology, you're thinking maybe there's a problem with the rhythm, so you want to check and assess your rhythm a bit further before you actually look at your rate on your ECG. Because remember, how you calculate your rate is going to be dependent on the rhythm as well. So I will show you some examples. Before I come to this, I'll show you some examples, and I'll be showing you the pictures for 5 seconds, and I want you to actually ask yourself, what do I see on this ECG? I just want you to answer whether it's a very fast rhythm, very slow rhythm, or ugly morphology. I'll do it very quickly, so please pay attention. Let's go. Okay, think about what you just saw. What do you think you just saw on the previous ECG? Is it a very fast rhythm, very slow rhythm, or it's an ugly morphology? Have your answer? So that's a very fast rhythm, as we can see, very fast. The QRS complexes are very close to each other. Let's move to the next one. Got your answer? Is it a very fast, very slow, or ugly morphology? Think about what you just saw. Okay, so here generally it's a very slow. As you can see, the QRS complexes, you can see they are somewhat, you can see the shape. They are spaced widely apart from each other. The next one. So think about what you just saw. Is it a very fast morphology, very slow morphology, or it's ugly morphology? So this is an ugly morphology. Again, this is just the general impression of the ECG. As you can see here, it's like there are these zigzag patterns that you can see everywhere. So these are broad QRS complexes. Okay, next one. Okay, again, think about what you just saw. Very fast rhythm, very slow rhythm, or ugly morphologies. So that's most likely ugly morphologies. So that's as much as you do when you're looking at the general impression. It gives you a general idea of what you are looking at on the ECG. It's not necessarily a diagnosis, but it will give you a general idea of what you're looking at on your ECG. So we'll move now to the next step, which is of course your rhythm determination. I like to put rhythm. If you see most ECG videos, they'll tell you that first calculate the rate, then come to the rhythm, but then remember that your rate is going to be dependent on the rhythm of the ECG. So I like to think of the rhythm before I look at the rate. So I'll do a quick assessment of the rhythm, then I'll come and calculate the rate, then I'll go and do an in-depth assessment of the rhythm again. So this is the most important steps, and remember that there are some rhythms that we'll talk about after we finish interpretation of the ECG on separate topics on their own. Sinus block, sinus pause, sinus arrest, atrial rhythms like premature atrial contractions, atrial flutter, atrial fibrillations, wandering atrial pacemaker, multifocal atrial tachycardia, ventricular tachycardias, ventricular fibrillations, polymorphic ventricular tachycardia. Those are some of the important rhythms that you should be able to remember and pick up on your ECG and intervene in your patients. So in rhythm determination, we're going to be looking at the regularity, we'll look at the rate, we'll look at the P waves, we'll look at the PR interval, we'll look at the QRS complex, we'll look at now how we're going to report this as our general interpretation when we come to determine the rhythm. Because when you are writing your ECG report, it must consist of the following things. So coming first to regularity, remember that an ECG could either be regular, meaning that there's a constant spaces in between the waves, or it could be irregular. Remember that the irregular rhythm could be either regularly irregular, meaning that there's a recurring pattern, or it could be irregularly irregular, meaning there's no recurring pattern. So often you're going to map out the RR waves. So from one R wave to another R wave on your rhythm strip, from one R wave to another R wave on your rhythm strip. And if you see that these are equidistant, you can actually use some calipers, you can use a paper, you can use a ruler to measure out these lengths. The more you practice on your ECGs, the easier it gets to actually just spot these out and actually say, okay, this doesn't look like as if they are actually regular. We can do this with the RR intervals as well as the PP intervals. It's nice to check on lead 2 because that's the one that you often get on your rhythm strip. Remember that if you're suspecting that there is some sort of heart block, meaning that if your PR interval you see that it's progressively increasing or your PR interval is increased, then you should at least check the PP intervals and the RR intervals, because as you move along the rhythm strip, you'll see that your PR interval is changing, and if the QRS complex begins to miss, or if there is complete dissociation between the QRS complex and the PR interval, then you should assess the QRS complexes on their own, you should assess the P waves on their own. So you're going to ask yourself some additional questions, very quick questions, not going into depth of this, very quick questions. Use lead 2 on the rhythm strip. Are the P waves present? Do the P waves look normal? Are the P waves appearing before every QRS complex, or are they married to every QRS complex and you have a T wave afterwards? Once your answers to all these questions are yes, then you can go ahead and determine the rhythm, rather the rate, because generally your baseline rhythm will be a regular one. So you determine your rate. If it's regular, there's mechanisms and ways in which we determine this. If it's irregular, there are ways in which we determine this. So now we determine our rate, whether it's regular or our rate is dependent on how the rhythm is, whether the rhythm is regular or the rhythm is irregular. But remember that a normal heart rate is 60 to 100 beats per minute. Tachycardia is greater than 100 beats per minute. Bradycardia is less than 60 beats per minute. So if you did your quick assessment of your rhythm and you notice that your rhythm is regular, there are two methods that we can use to determine what the rate is. I like to use the one which uses the small boxes. So you just simply say 1500 divided by the number of small boxes between either the RR intervals or between the PP intervals. Then if there are big boxes that are in between these waves, we'll use 300 divided by the number of big boxes between the RR or PP intervals. But remember what I told you earlier on. If you're suspecting that there's a heart block, there's an increase in the PR interval, you should calculate the atrial rate on its own, 1500 divided by the number of small boxes between PP waves, and the ventricular rate on its own, 1500 divided by the number of small squares between the RR intervals. It's a bit much more accurate when you use these small squares, because sometimes you may not have straight, clear-cut big boxes in between these waves, but the small boxes will always be there. So here is an example. So as we can see here, from this R wave to the next R wave, you have 1, 2, 3, 4, 5 boxes. So we have 5 boxes in between these R waves. So 300 divided by 5, it gives us 60. So the heart rate of this ECG is 60 beats per minute. A nice hack or a nice shortcut I like to tell my students is, if you have 3 to 5 small boxes, or rather 3 to 5 big boxes, most likely your rate is normal. If you have less than 3 boxes, meaning your waves are very close to each other, most likely this is a tachycardia. If your waves are far apart from each other, more than 5 big boxes, this is most likely a bradycardia. So keep this hack in mind. Now, you may get sometimes where you assess the rhythm and you look at the rhythm and you see that it's irregular. For example, what we are looking at here, you look at the distance from this wave to this wave, it's almost similar to the distance from this wave to this wave, but look at what's happening here. The distance here has increased. Remember that your ECGs must come with a rhythm strip. And I talked about the rhythm strip in the previous video. That is why I emphasize on you watching that video first. So we assume that our rhythm strip is a 6-second rhythm strip. And what do we know about the 6-second rhythm strip? It should have 30 big boxes. So if you count from here to here, there are 30 big boxes. So you count 30 big boxes on your rhythm strip, and you count the number of QRS complexes that are present in that rhythm strip. So 1, 2, 3, 4, 5, 6, 7. You have 7 QRS complexes present in this rhythm strip. You multiply that by 10, because if it's 6 seconds for 1 minute, it's going to be 6 multiplied by 10. So your rate here will be 70 beats per minute. You have to remember that if your rhythm is quite extremely irregular, it means that it's best for you to count the RR intervals for a full minute, so for 60 seconds. So like I said, on your rhythm strip, you're going to have these small marks at the end of your paper to signify and tell you that, okay, this here is 3 seconds, so meaning from here to here, you have 15 boxes. Then from here to here, you have another 15 boxes. So it means to determine the rate of this ECG, you're going to be counting the QRS complexes from this box here to this box here. So if we count the QRS complexes, we have 1, 2, 3, 4, 5, 6, 7. 7 multiplied by 10, so this rhythm must be, rather the rate must be roughly around 70 beats per minute. So here's an ECG. I want you to pause the video right now and calculate the rate. It's very important that you must do these things, because these concepts are very volatile. If you don't do the examples, you won't be able to get the principle on this particular ECG. So pause the video right now, calculate the rate, determine the rhythm first, a quick assessment of the rhythm, and then calculate the rate for this ECG. And here comes the answer. So if you count in between these, let's say we're using this is slightly starting here, it's not starting at the first, and this is slightly into there. So you can think of this as almost one box. So 1, 2, 3, 4. So you have like about 4 boxes in between these RR intervals. So 300 divided by 4, that gives us roughly about 75 beats per minute. So this ECG would be roughly around 75 beats per minute, which is a normal heart rate. What about this one? Again, pause the video to calculate and see for yourself. And whenever you're calculating these rates, make sure you use points that are very clear and the ones that are easy for you to follow. The most clear points and the ones that are easy for you to follow. It's best to use the rhythm strip. Okay, you have your answer. And here goes. So here, if you count the number of small boxes in between, of course, they are about this 1 to about 10, and this is not at the end, so it's like one small square. So 1,500 divided by 11 small squares gives us roughly around 136 beats per minute, which is a tachycardia. As you can see already, these are like very close to each other. So after we have done that, now we have assessed the rate. Remember, first is a quick rhythm assessment, then we come to assess the rate, then we assess the P waves, then we assess the PR interval to actually assess the other different types of waves to see if the rate is actually, or rather the rhythm is regular. So when we come back to the P waves, we should ask ourselves, are the P waves upright in all the leads except for lead AVR? Are they round? Are they married to a QRS complex? Meaning, is there a P wave before every QRS complex? Is the duration normal? So remember that your P wave should be 2 boxes wide. So if it's the P waves are broad, it means that they'll be larger than 2 boxes wide. Then that means that that's already abnormal. The next thing is the PR interval, remember, which is from the beginning of the P wave to the beginning of the QRS complex. It should roughly be 0.12 to 0.2 seconds, so between 3 to 5 small boxes, and it should be constant. So if you look at this ECG at the bottom, the PR interval is constant. There are some times where your PR interval may actually increase. If your PR interval increases, it means that the impulse is taking longer to move from the atria to the ventricle. So there's some sort of heart block that is there, the different degrees of heart block that I'll talk about in a separate lecture. First degree, second degree, and third degree. If the PR interval is shortened, it means that your impulse is traveling very quickly from the SA node through the atria, even into the ventricle. That could be a problem that we see in maybe a channel, or maybe there's an ectopic tissue that is near the AV node, or there's this channel that is conducting faster than the AV node, which is what we can see in Wolff-Parkinson-White syndrome. When we come now to the QRS complex, we ask ourselves, are they normal? Are they less than 3 small boxes? Remember, at this particular time, we're not assessing the height of the QRS complex, we're just assessing the width. If they're less than 3 small boxes, the angles are steep, they have sharp points, they're not curving, then it's not pathological. If there's widening of the QRS complex, they are broad, that means that there's a problem there, they're abnormal. So, how do you comment on the rate and the rhythm of this particular ECG displayed on your picture? You may pause the video at this particular moment. I'm sure you have your answer written down. Now let's go through it. So if we look at this ECG, of course we can count the number of squares that are in between the different waves here, from this particular wave, the first wave here, to the second wave. As you can see here, there's about 1, 2, 3, 4 big boxes. So we can say about 4 big boxes, that's 5, 10, 15, about 19. So about 19 boxes that are there. So if we actually say, so that's 5, 10, 15, 16, 17, 18, 19, or 20, 21, 22. So about 22 rather, not 19. So if we say 1,500 divided by 22, somewhere around 68 if we're calculating it. But the rate of this was roughly around 71 beats per minute. Our rhythm is regular. How do we know this? There are P waves, and our P waves are about 2 boxes. As you can see, this one is here about 2 boxes wide. Each P wave is followed by QRS complex T wave. P wave, QRS complex, T wave. P wave, QRS complex, T wave. All our P waves are upright. They are uniform. Our PR interval, we look at it for 3 consecutive waves. So we have 1, 2, 3, or 4. Here we have 1, 2, 3, 4, okay, which is normal. 1, 2, 3, 4, which is normal. So our PR interval is normal and it's constant. Our QRS complex duration is within 1 box, so it's normal duration. They're narrow QRS complexes. So this is a normal sinus rhythm, and that's how you're going to report it, because all the findings here are normal. Remember that a normal ECG would not exclude heart disease. Now what about this other one here? Comment on the rate and the rhythm. This was also gotten from lead 2. You may pause the video again. Okay, and here comes the answer. So as you can see here, there are about 6 boxes. 1, 2, 3, 4, 5, 6 big boxes. So 300 divided by 6, that gives us 50. So already you can tell that these are wide apart from each other. So there's some sort of bradycardia that you can actually see here. We can see that the P waves are present. They're about 2 small boxes each. The P waves about 2 small boxes wide. And each P wave is followed by a QRS complex T wave. The P wave, QRS complex, T wave. P wave, QRS complex, T wave. We measure the distances from here to here. It's the same as from here to here. It's the same as from here to here. So the RR intervals are the same. The PR interval here, 1, 2, 3, 4 again, which is normal. 1, 2, 3, 4 again, which is normal. 1, 2, 3, 4 again, which is normal. 1, 2, 3, 4, which is normal. The PR interval is normal. Your QRS complex duration is within 1 small box, which is normal. And then of course you have these sharp angles and you have these steep QRS complexes. The only thing that was remarkable of this patient is that they had a slow heart rate. So we see this and we call it as a sinus bradycardia. We see it in athletes, we see it when a patient is sleeping. Even in acute MI, it's actually quite protective and it's beneficial. We can also see it in patients that are on certain drugs that slow the heart rate, like beta blockers. It may cause sinus bradycardia because there is a slow firing of the SA node. Moving on to the next example. Again, pause the video. I want you to comment on the rate. I want you to comment on the rhythm. I'm sure you must be getting the hang of it by now. Okay, here's the answer. So again here, we can see that the number of boxes here is very small. So here we have 1 square, then here we have 1, 2, 3, 4. So we have about 9 squares. So 1,500 divided by 9, which can give us somewhere around 166.66 something, so 167 beats per minute. We can see that number 1, your RR intervals are constant, so obviously this is like a regular rhythm. We can see that there are P waves that are present before the QRS complex. There's a T wave, a P wave, QRS complex. Each P wave is at least 2 boxes. Our PR interval also appears normal. If you can calculate and you can count those squares, it appears normal. Your QRS complex duration is normal. So this is a patient that had a sinus tachycardia. This can be seen in anxiety, it can be seen in patients that are exercising, it can be seen in patients that are scared, patients with hypoxemia, hypovolemia, even patients with cardiac failure. It's because there is increase in discharge of the SA node. We come now to this one. I want you to comment on the rhythm and the rate, if you can. Okay, I hope you have your answer. So already you can look, when you look at this ECG very quickly, you can see that the length from here to here is not the same as from here to here, it's not the same as from here to here. This is already an irregular rhythm. So it means on your irregular rhythm, you can calculate your rate using, of course, your 6-second method. Here, there are 30 squares that are displaced here. So we count the ECG QRS complexes: 1, 2, 3, 4, 5. 5 multiplied by 10, that gives us 50. So this person is at 50 beats per minute. Our P waves, though, are present. We can see there's a P wave here before the QRS complex, P wave before the QRS complex, P wave before the QRS complex here. Our PR intervals also seem to be constant if you're actually looking at them, and your QRS complexes are also constant. The only thing that is rather irregular here is the rhythm of the patient. As you can see here, these waves are much far apart as compared to these particular waves. Next example, this one is even much more obvious. You may pause the video, and here comes the answer. So again, here it's a bit regular when you look at here to here, here to here, here to here, but look at what's happening here. It's like this person has completely no activity. So it's like as if the activity of the sinus has been paused. So we call this as a sinus pause or a sinus arrest. So here we can see that there are P waves when there's cardiac activity and they're upright. As we can see here, they're upright and they are preceded, or they're preceding the QRS complexes. There are 2 small boxes wide. The QRS complex is narrow, 1 small box width. Then of course it has sharp angles, but the only thing that is a problem is this point here where there was absolutely no activity. There was a sinus pause. So this is what we call a sinus pause. Here's another one. I think this should be towards the end. This must be the last example. You may pause the video. Again, if you notice from this particular ECG, you can't see any P waves. You can't identify which one of those following squiggly lines here is a P wave. Very difficult to identify the P wave. Very difficult to identify the T wave here because there are a lot of these small fluctuating waves. There's a lot of chaotic activity that is happening. You can't even determine the PR interval here, though your QRS complex is normal. One thing that should give you a hint that the problem is in the atria is if your QRS complexes are narrow, it means most likely your problem is coming within the atria. If they are broad, it's most likely coming from below the atria. So most likely this person has an atrial fibrillation. Usually the atrial rate would be 350 beats per minute or greater, and the ventricular rate would be much slower, because if we count the QRS complexes in this rhythm strip, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it means that their ventricular rate will be at 100 beats per minute. So remember where we're coming from and remember what we've tackled so far. This 7-step interpretation of the ECG, we've looked at step 1, patient and ECG details. Step 2, determining the ECG calibration. Step 3, general impression of the ECG. Step 4, looking at the rhythm interpretation, looking at the regularity, the rate, the P waves, the PR intervals, your QRS complex, and giving an overall interpretation of the rhythm. In the subsequent videos, we'll look at the interpretation of the QRS complex. We'll look at picking up different types of hypertrophy on the ECG, as well as ischemia and infarction. If you liked this video, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.